Years ago, family physicians and general internists took care of their hospitalized patients. The admitting physician knew his or her patient, their medical history, their family, and social circumstances. A decision was made by the insurance industry that primary care physicians needed to be driven out of hospital care of their patients. The belief was that a physician who specialized in care of hospitalized patients was more competent and would provide a more cost-effective way to care for patients when they needed to be hospitalized. The result has been that when patients are most vulnerable and anxious, the patient and their families must engage with physicians who have extremely limited knowledge of the patient and their circumstance. It was assumed that the electronic medical record would serve as a clinical information bridge between the primary care physician and the hospitalist. This turned out to be inaccurate. The EMR does not work this way in most cases. Instead of the medical error rates going down, they went up. To reduce the rates of unnecessary care, to increase patient satisfaction, and to decrease the medical error rate, there is a need to find a way to re-engage primary care physicians in the care of their patients who need hospital services. The primary care physician does not need to be the physician of record. Knowledge of the patient and the patient's problem and their circumstances needs to be available when the patient first engages the hospital through the emergency room, at certain points during their course of care while hospitalized, and during the discharge planning process. This needs to be done with two things in mind. First of all, time needs to be made available in the primary care physician's schedule to engage in this way, and the primary care physician needs to be fairly compensated for this valuable service, which will reduce unnecessary hospital admissions, readmissions, and unnecessary care. Enter stage left, the robot.
Hi, Mr. Roberts. Good morning. How
Good
are
morning.
you?
I'm okay.
How are you doing?
I'm fine. How are you?
I'm well, thank you. We were hoping to discharge you today and send you home with some new medications.
Today?
Yeah, today. You had a blood clot here, so we wanted to send you home with some Lovenox.
Oh, I don't know how I feel because I'm already on a ton of medications and I don't know.
Do you know the name of any of your medications?
I know a few of them, but my primary care doctor, Dr. Meehan, he knows them all, and I don't know if I can go home today. I don't know how I feel.
Actually, I know Dr. Meehan very well. If you don't mind, I can give Dr. Meehan a call and see if he will stop by virtually.
Okay, sure.
Okay.
That sounds okay.
Hello? Hi, Dr. Meehan. Would you have a couple of minutes to stop by and see Mr. Roberts? Thank you. He'll be coming in a couple of minutes.
He'll be here?
Yeah, he'll come in virtually.
Okay.
All right.
Okay, thank you.
Can you see me?
Oh, Dr. Meehan, is that you?
Really?
Hi, Dr. Meehan.
Hi, how are you? So good to see you.
I'm okay, Dr. Meehan. This lovely doctor's trying to tell me about some new medicines. I told her to talk to you.
So, hi, Dr.
Excellent.
Meehan.
Thank you, Dr. Todd, for calling me in. What questions can I answer?
We were hoping to send him on Lovenox today. I know he had some concerns about other medications, and we wanted to ask you what you thought.
Well, I can look through his chart right here. As far as I'm seeing, so as you probably know, he has a history of hyperlipidemia, and that's really it. The only medications you're taking at home are the aspirin I gave you last year. I started you on atorvastatin 40, and that's pretty much it. I'm not seeing anything else that would contraindicate you from having the Lovenox. I may want to hold off on the aspirin for a little bit, considering that you're going to be on Lovenox for a little while, and I don't want you to bleed. But other than that, that's it.